Hello, my name is Dr. Richard Sawyer and I've been a radiologist in Manchester for more than 30 years with a special interest in lung diseases. I'm going to cover nodules, especially miliary nodules today, and looking at tuberculosis but also the differential of this sort of pattern of disease. So the main objectives are how to recognise both on radiographs and on a CT scan when the pattern is miliary, the differential diagnosis of both miliary disease and also other pulmonary nodules, and I want you to be aware that miliary tuberculosis is an extremely serious disease and needs prompt management. This is the outline of what we're going to be covering: the miliary definition, the risk factors, pathophysiology, and then a look at the imaging findings. Miliary tuberculosis is uncommon, but because it's so serious, it's important to be aware of and have a low threshold for diagnosing, or at least suggesting, that this might be miliary tuberculosis. It's when tuberculosis spreads uncontrollably throughout the body because the mycobacterial infection growing in the lung has spread into a blood vessel and then gone into the systemic circulation. Unfortunately, only about 3/4 of people have got a typical chest radiograph, and clearly it depends at what stage you're seeing the patient in their history. There are several other diseases which can have a similar pattern, both tumours and other infections, and we'll cover that later on. It's important to understand the pathophysiology of tuberculosis, and I make no apologies for going through this in some detail. When you first get tuberculosis, there is an area of infection in the lung which looks basically like consolidation, and there's a reactive lymphadenopathy which goes with that. This isn't commonly seen, and in Britain I've only seen this once with a good example in a young child. Sometimes you'll get a pleural effusion, and sometimes there's just a small focus of consolidation and minor lymphadenopathy which you recognise later because of calcification in those two areas. This is the so-called primary complex. Secondary tuberculosis then is when the TB reactivates, so it can be called either reactivation or post-primary TB. It's the same thing. For some reason, either the host's immunity has reduced slightly and the patient's infection takes a hold again. Typically, or classically, this is in the upper parts of the lung, so either in the apical segments of the upper lobe or in the apical segments of the lower lobes. Typically, there's an area of cavitation as the TB destroys the adjacent lung. And the thing then to recognise is, depending where that cavitation extends to, determines the pattern of disease we then get. For example, if it spreads into the pleura, you will get a pleural effusion or a pleural empyema. If it spreads into an airway, even a reasonably small one, the pus, the infectious organisms in the cavity will then spread to the airways and cause widespread endobronchial disease. Miliary TB is when the blood vessels are invaded by the infection, and this then goes into the pulmonary veins, through the heart and out into the systemic circulation, causing very widespread seeding of small areas of infection. Worldwide, HIV is the most common cause of the reactivation, but other causes of immunosuppression are also relevant. Sometimes pulmonary TB can be atypical in HIV, and the key thing to know then is the CD4 count. You need a high index of suspicion in patients with HIV in order to attack the disease early. Sometimes you may get diffuse involvement rather than the classical upper lobe changes. And sometimes you may get a primary pattern, as I described earlier, with an area of consolidation and lymphadenopathy, perhaps with a pleural effusion. And then this can lead on, without the intervening years of being well, to the miliary pattern and possibly even pericardial effusion. So low CD4 counts significantly increases the risk of miliary TB and also pericardial effusion. So miliary TB is only a small subset of all cases of TB, but because the prognosis is so bad, because the disease has spread so widely, it's important to recognise. I'd like you to be aware that it's very rare for miliary TB to cause calcification, and certainly not at the acute stage. So if you see multiple small foci of calcification in the lung, you need to be thinking of other diagnoses. There's a particular risk in youngsters of TB meningitis, but this is not just for youngsters. There's also a significant risk when you're older. Risk factors for miliary TB. We've mentioned HIV as a cause of immunosuppression, but cancer, immunosuppression in order to reduce rejection in transplantation, malnutrition, diabetes, renal disease can all give you enough immunosuppression to let miliary TB get a hold. The pathophysiology of miliary TB involves erosion through the epithelial layer of the alveolar cells, and this then allows the organisms to spread into a pulmonary vein. These lodge through the tissues of the patient and activate a cell-mediated immunity. We then get macrophages which converge on the area, and these form small granulomas. And it's these granulomata which are the cause of the miliary pattern. Essentially, all organs in the body can get affected. I've just listed a few here. The important thing is to recognise that if not treated, miliary TB is almost 100% fatal. Even with treatment, there's still a significant mortality, unfortunately. The clinical background is important, even as a radiologist, because the onset can be insidious and the patient may not be as acutely ill as you'd expect somebody with widespread tuberculosis to be. Sometimes non-specific symptoms, chills, cough, anorexia, and it's very common for the person to have an enlarged liver because of spread there, and lymphadenopathy also. Typically, it takes several weeks for this small foci of disease within the tissues to develop enough to radiologically appreciate the disease. If you think about it, a single mycobacterial organism can't be seen on the CT scan. We have to wait for the cell-mediated immunity to cause these granulomas. And depending on what stage we catch the patient at, up to a third or so may have a normal chest radiograph. Sometimes if you do a CT scan, you may appreciate the granulomata. So what do we see? In the majority of these patients where we see an abnormality, you see innumerable myriad non-calcified nodules. Typically these need to be picked out with a pair of forceps to give you an idea of how small they are. If you could pick up the nodule with your fingers, then they're not miliary. Miliary are extremely small. The nodules may be poorly or well defined, depending on the degree of cell-mediated immunity, and characteristically they have a random pattern through the lungs. I've already mentioned that CT may be more sensitive. Here's a photograph of miliary that doesn't quite give the scale. This is about 2 millimeters in diameter. On the left is a typical radiograph. Innumerable tiny nodules scattered throughout the lungs. Remember that the thickness of the pulmonary parenchyma varies, being thinner at the apices, the bases, and at the edge of the lungs. So the actual number of nodules may appear to change slightly, but the distribution is very characteristic. It affects all the lungs. Here's a slightly more subtle example, but still I think you can appreciate both on the lateral and the frontal film that there are numerous tiny, perhaps slightly less well-defined nodules here. This is a much more subtle example, rather soft, poorly defined, but numerous tiny nodules easier to appreciate on the zoomed in image on the right. The pathological specimen shows what we're trying to image on the CT scanning. These are the small granulomata scattered throughout the lung. CT is a much more sensitive and also a much more specific way of demonstrating these lesions because it gives you no superimposition of the nodules. You can see how well they're scattered through the tissues. Typically nowadays we'll use high resolution scanning with very thin sections, and normally when people are unwell we're not worried about the radiation dose and we'll do a spiral scan or a helical scan through the whole of the patient. The technique that I've mentioned here as number one is the technique we use when we're worried about radiation and we're just trying to sample the lung parenchyma, perhaps to appreciate fibrosis or perhaps bronchiectasis, where we're wanting to have a small slice, perhaps 1-2 millimeters thick, and then the patient's moved and another slice is performed. This reduces the radiation dose down to about 10% of a normal scan. Nowadays though, volumetric scan, helical scanning is much quicker, much easier to perform, and it's easier for the patient as well. You get a much more consistent scan. It's also a technique we use for looking for lung cancers, which may coexist with tuberculosis. The kilovoltage is fairly typical, 120 to 140, and the milliamps can be reduced depending on the make of the machine. Typically a scan time of 10-15 seconds. We try to keep the time as low as possible because these patients may be quite unwell and breathless. It's much easier to look at the scan if it's all performed in one breath hold. I've mentioned a technical factor of keeping the field of view down to make sure that the resolution of the images are the best we can achieve. And normally these images are looked at on a computer monitor, but if you are filming then you need to look at it on a lung window, 1600 width, but also on a mediastinal window. I've said we do it in inspiration, and for tuberculosis, prone views and expiratory scans aren't helpful. These are performed looking more for airways or interstitial lung disease. One technique that is useful both for tuberculous nodules and also for cancers is to perform these maximum intensity projections. I like to do these as a slab, perhaps 5, 10, 15 millimeters thick, and these show nodules much more easily. Here then is a good example of tuberculosis. Widespread nodules scattered through the lung, randomly through the tissues, some at the very edge of the lobes and some more centrally. Let's have a look at the differential diagnosis of nodules. Perhaps the first way to classify pulmonary nodules is by how well the person is, whether they've got a fever or not. If there's a fever, the typical infections are tuberculous, fungal, viral, but hypersensitivity pneumonitis in the acute phase may also cause small nodules and a pyrexia. If the person's afebrile, then this doesn't exclude TB or fungal disease, but tumour is perhaps slightly more likely then. And tiny nodules are seen with thyroid, renal, breast, osteogenic sarcoma are particularly classical. Langerhans cell histiocytosis is uncommon and thought to be largely a reaction to cigarette smoke. Certainly the patients I've seen are usually at a later stage, but occasionally you'll see them presenting with tiny nodules through the lung. Silicosis is an important diagnosis, so a good occupational history is vital, looking for tunnellers, coal workers and so forth. The differential of multiple nodules is perhaps easiest done with whether they are located against the pleural or whether they're scattered through the lung. If there aren't any pleural nodules, typically these are centrilobular lesions, such as in hypersensitivity pneumonitis, infection, or sometimes with cancer which is spreading through the airways. So this is airway sensitive disease. The airways are the way of transmission of either the cancer or the infection. If there are pleural nodules, this may be because of a peri-lymphatic process, and we see this with sarcoid, silicosis, and also cancer that's spreading through the lymphatics of the lung. Or, as in this talk, miliary infection due to tuberculosis and occasionally fungal disease. Metastases, unfortunately, also can scatter randomly through the lung because they're also hematogenous. We can also classify nodules by size. So these micronodular lesions, which include miliary TB, can also, similar things can also be seen in histoplasmosis and coccidioidomycosis. Clearly this is a geographical predilection, and knowing where the person has been living or possibly travelling to is very important. Small areas of nodularity are seen in bronchiolitis, viral infections and mycoplasma characteristically. We also see very small nodules with sarcoid and hypersensitivity, as I've already mentioned. It's rare to see numerous micronodular metastases, but bronchoalveolar cell carcinoma, where tiny areas of tumour have spread throughout the bronchial tree, are characteristic of this. And also occasionally we'll see lymphocytic interstitial pneumonia. We've already mentioned silicosis and Langerhans cell histiocytosis. Slightly larger nodules, between 5 and 10 millimeters, have got a slightly different differential. Infection includes varicella due to chickenpox, fungal disease, neoplasm, metastases. The slightly larger nodules have got a very similar differential. Thinking of infection, this is perhaps more transbronchial spread with regard to tuberculosis. Varicella, which is a hematogenous spread through the lung of chickenpox. Fungal diseases, tumours and metastases. Pneumoconiosis and sarcoidosis can also produce these larger nodules. I've already mentioned that it's not typical to get calcification with tuberculosis. So if you see very dense lesions, then you should be thinking of a slightly different differential. The commonest thing we see in Britain is healed varicella pneumonia and silicosis, and rarely pulmonary alveolar microlithiasis with numerous myriad tiny micronodular areas of calcification are seen. Occasionally we'll see calcified metastases from osteosarcoma, and rarely chronic, long-standing, severe mitral stenosis can give pulmonary ossification with pulmonary hemosiderosis. Occasionally it's idiopathic. Let's look then at this peri-lymphatic spread of disease. You can appreciate on the right-hand image where the yellow dots of disease are spreading along the interlobular septa, particularly towards the right-hand side of the image. So these are along the lymphatics which separate each primary pulmonary nodule. On the left you can see widespread disease here, much more along the line of the bronchus with thickened bronchi. They're not dilated, it's not bronchiectasis. This is tumour spreading along the airways. Silicosis is also a peri-lymphatic process. You can appreciate on this scan that mostly the peripheral zone of the lung is clear of any visible markings, but anteriorly in the patient's left lung you can see that there are some areas where there are lines going to the pleural surface. There are also in the patient's right lung several rather subtle subpleural nodules. This person had been a tunneler, and the diagnosis therefore is relatively straightforward at silicosis. Here's a patient with sarcoidosis. Here we've not only got nodules, but you can see that the bronchial walls are thickened, slightly irregular. Sometimes these will appear beaded, and there are areas of fibrosis as well. There are nodules scattered both peripherally, you can see posterolaterally in the right lung and also around the periphery of the left lung. So this is a very different distribution to what we see with pulmonary TB, where the nodules are scattered randomly through the lung. If there's an inhalational problem or a spread through the airways, then we'll tend to get a centrilobular pattern. So this is a patient who's aspirated, and there are numerous small nodules sitting within the central lobular area. In the right-hand image you can see the interlobular septa outlined in white, and the yellow represents different ways, different patterns which can affect this centrilobular area. Widespread differential here, but infection, hypersensitivity, cancer, and also fluid, either edema or aspiration. We've already mentioned Langerhans cell histoplasmosis, which can be thought of as a reaction to cigarette smoke. Here is a patient who has a hypersensitivity to birds. The nodules are really rather more ill-defined areas of ground glass shadowing, sitting centrally within the primary pulmonary lobule, but it still produces a rather ill-defined nodularity across the lungs. A similar pattern is seen in patients with viral pneumonia. Here is an example of a patient with miliary metastases, in this case due to thyroid disease, but the list on the right is very typical: thyroid, kidney, breast, sarcomas, especially osteosarcomas. Here's another example of a patient demonstrating multiple small nodules, rather poorly defined here and rather subtle. The diagnosis was miliary tuberculosis. This is a patient, younger patient, with slightly less good quality image, but I think on the zoomed in image on the right you can see these numerous small nodules. As I said before, the areas where you live, the geographic distribution is quite important, but you've got to remember that a lot of people travel, and therefore if the person's been living or staying out in these areas in the Americas, they may have picked up an infection. Histoplasmosis, sometimes in AIDS, can also be miliary, but you can also get areas of frank consolidation. So here in the left lung, the nodules are perhaps more discrete, whereas they're starting to become more confluent, particularly in the right upper zone. The Americas, Asia, and probably also Africa should be considered as possible areas for histoplasmosis. The patient doesn't have to have any immunosuppression to have histoplasmosis. Here's a youngster with numerous small nodules in both lungs. A CT scan shows a similar sort of effect to that we've seen with miliary tuberculosis. This is a slightly unusual presentation of a patient who's had a massive exposure to fungal organisms due to working with bark chippings. They've breathed in large amounts of Aspergillus, and there are numerous nodules scattered through the lungs. If you look at the distribution of this on a CT scan, however, you'll see that this is more airways related. This isn't the typical random pattern that we've seen on the CT scans. This patient has had varicella pneumonia. If the person was acutely unwell, these nodules would be much less white, much less dense, but now this is long time afterwards and the nodules have calcified. I've put this down as a diagnostic dilemma, but actually the distribution of these nodules may look the same, but the density of the nodules is very different. So on these lung settings, it looks identical, but if you window these with a mediastinal window, you'll see miliary TB are soft tissue nodules, but the calcified breast nodules and the pulmonary alveolar microlithiasis are all calcific. So the distribution is the same, but the diagnosis is very different. So it's important to recognise the patterns of miliary nodules and whether they're airways related or scattered randomly through the lung. The size is important, and also the patient history. What I want you to do though, however, is if you see a miliary pattern, at least think of tuberculosis first, because the prognosis is so much better treated early. Thank you very much.